From question number 21, right? So we have an 82-year-old woman is sent to the hospital from a nursing home after 2 days of fever, confusion, and lethargy. The patient has a history of mild dementia, hypertension, and osteoarthritis. Her temperature is 38.8 degrees centigrade or 102 degree Fahrenheit. BP is 90 by 60 mm of mercury, and pulse is 116 per minute. She has mild suprapubic and right costovertebral angle tenderness. Her leukocyte count is 18,000 per millimeter cube, and urine analysis is consistent with acute cystitis. Femoral vein excision planned, right? Point to be noted. For administration of IV fluids and antibiotics, the femoral artery pulsation is palpable immediately below the inguinal ligament. Which of the following best describes the optimal cannulation site for the femoral vein? So they're asking about optimal cannulation site, right? Option A, immediately lateral to the femoral artery. Option B, immediately medial to the femoral artery. Option C, midway between the iliac crest and femoral artery. Then option D, superior and medial to the pubic tubercle. Option E, superior to the inguinal ligament. Pause it and give the answer, right? So the correct answer for this question is um, immediately medial to the femoral artery, right? Let us see to the explanation how this could. Let me select this for you guys. Okay. So if we look at the femoral triangle, right? Uh, this one over here is the inguinal ligament, right? Then from medial to lateral, they are arranged uh, in the form of vein, right? That is vein, artery, and nerve, right? Femoral vein, femoral artery, femoral nerve, right? Then we have the lateral wall of the, you should remember these things, three things, right? In femoral triangle, the lateral wall is formed by sartorius muscle, right? This one. And the medial wall is formed by the adductor magnus muscle. This is important, right? And the superior wall that is made by inguinal ligament, right? So these things are important. And with that we have this great saphenous vein, right? This one which would drain into the femoral vein, right over here, and with this one, and they would form common femoral vein, right? So femoral vein catheter placement is usually done in patient with unavailable preferred exit sites, right? If these are not available, like subclavian and jugular vein, are those at increased risk of complications, for example emergency access or uncooperative patient, right? The femoral vein is the major deep vein, right, of the lower extremity, right, and passes through the femoral triangle beneath the inguinal ligament before entering the pelvis is the external iliac vein. So when entering into the uh, in into the pelvis, right, before that it would be external iliac vein. When it get enters, then it would form what, the femoral vein, right? So the femoral triangle is sufficient space in the upper thigh that is bordered by the inguinal ligament superiorly. I talked about this. Adductor longus muscle medially and sartorius muscle laterally, right? Within the femoral triangle lies lateral to medial, right? This is important. Lateral to medial, we have femoral nerve, femoral artery, femoral vein, then deep inguinal lymph nodes. With that, lymphatic vessels. Femoral artery is located at the in mid-inguinal point. This thing is important, right? Midway between the pubic symphysis and anterior superior iliac spine. They mean to say, let's say this is anterior superior iliac spine, then over here we have pubic symphysis. So over here in this mid we have femoral artery, right? Okay. Cannulation of the femoral vein should approximately 1 centimeter below the inguinal ligament and 0.5 to 1 centimeter medial to the femoral artery pulsation. Minor option E, femoral nerve is approximately 1 centimeter lateral to the femoral artery and could be needle insertion at that site. Okay. So educational objective is that femoral triangle lateral to medial consists of femoral nerve, femoral artery, femoral vein, deep inguinal lymph nodes with that lymphatic vessels. Cannulation of the femoral vein should occur approximately 1 centimeter below the inguinal ligament and the femoral artery pulsation. Now question number 22. A 72-year-old man comes to the emergency department due to left-sided weakness and sorry, and speech difficulty upon awakening this morning. Medical history include hypertension and persistent AFib. His anticoagulant medication was stopped 6 months ago after an episode of gastrointestinal bleeding. BP is 160 by 90 mm of mercury and pulse is 88 per minute and irregular. Examination shows mild dysarthria, left lower facial weakness with that left hemiparesis. CAT scan of the head shows no evidence of intracranial bleeding. Point to be noted. Okay, transthoracic echocardiogram shows left atrial enlargement, right? A normal left ventricular systolic function, mild mitral regurgitation. The patient's symptoms are determined by a cause to be caused by thromboembolic event. Which of the following is the most likely source of this thrombus? Option A, crista terminalis. Option B, left atrial appendage. Option C, left ventricular apex. Option D, mitral valve. Option E, pulmonary veins. Option F, right atrial appendage. Option G, sinus of Valsalva. Pause it and give the answer. So the correct answer for this question is left atrial appendage. Let us see to the explanation, right? So atrial fibrillation with thrombus formation. Here, if let's say the process of atrial fibrillation is going right, and this one over here is left atrial appendage, and over here there is blood clot, right? And over here we can see this one is the right ventricle, right? And with that, this one is the right atrial appendage. So atrial fibrillation is associated with significant risk of systemic thromboembolism. Point to be noted. Therefore, long-term anticoagulation is often recommended in patients without any confounding contraindications. For example, recent GI bleeding. Okay, several factors contribute to thrombosis development in atrial fibrillation. Left atrial enlargement, blood stasis due to ineffective atrial contraction, and atrial inflammation and fibrosis exerts a procoagulant effect, right? One thing you should to be remembered is that we have ranking of different markers. If let's say if we are using um, this yellow one, right, this is grade 1, right? And if let's say if we are using this red one above, right, this is grade 2, more important than grade 1. Then this green one, right, this is grade 3, important than red one. And this one is the final, the uh, this one, the blue one has grade 4, right? Let me draw this for you guys. Yeah, I was talking about this one has grade 4. This is most important point to be remembered. Okay, so now the left atrial appendage is a small sac-like structure in the left atrium that is particularly susceptible to thrombus formation, right? Approximately 90% of left atrial thrombi are found within the left atrial appendage. Okay, in patient with non-valvular AFib, right? These clots can be systemically embolized and can lead to stroke, as in this patient. Also, that can lead to acute limb ischemia with that acute mesenteric ischemia, right? So three things: systemically embolize, right, can lead to stroke with that acute limb ischemia or acute mesenteric ischemia. Why not option E? Because the crista terminalis, that refers to thick band of atrial muscle, right, that separates the smooth sinus venosus from right atrial appendage and atrium proper. Okay, this thing to be noted. It is the site of origin of the atrial pectinate muscles, right, and is not significant region of thrombus formation in the atrial fibrillation, right? Now, left ventricular apical thrombosis poses risk of systemic embolization and stroke, but it is typically only develops in patients with left ventricular aneurysm, right, or severe left ventricular systolic dysfunction. But in this case, the systolic function was normal, right? Left ventricular systolic, and it is not associated with atrial fibrillation, right? Final option D, prosthetic wall thrombosis can occur with bioprosthetic or mechanical mitral valves, right? Point to be noted. In patient without adequate anticoagulation, thrombus formation on a native mitral wall is extremely rare, right? Especially when wall function is normal or near normal, right? Final option E and G, thrombosis of pulmonary veins or sinus of Valsalva, that is aortic sinus, is rare and not associated with atrial fibrillation, right? Final option F, because the thrombus formation can occur in right atrial appendage with atrial fibrillation, right? It can occur, but it is less frequently than in the left atrial appendage, right? A right atrial thrombus poses risk of embolization to the pulmonary rather than systemic circulation. Let's say this is the heart, right? So if let's say the problem is in the right side, so that will go to the lungs, right? If the problem is in the left side, right, so that will go to the systemic side, right? So this is the difference. Okay, so for example, that would lead to pulmonary embolism. Okay, atrial fibrillation is associated with increased risk of systemic embolism. We talked about this thing. Left atrial appendage is the most common site of thrombus formation in atrial fibrillation. Okay, continuing question number 23. An 18-year-old man comes to the clinic due to hematuria and intermittent left flank pain of several months duration. He has no history of trauma or sexually transmitted disease and no associated fever or dysuria. Examination reveals a soft abdomen with normal bowel sounds and no localized tenderness. Urine analysis confirms three positive blood but no WBC, right? Crystals are organisms. Contrast enhanced CAT scan shows no abnormalities in the ureters or kidneys, but does reveal compression of the left renal vein between the superior mesenteric artery and the aorta. Which of the following is most likely to develop due to the vascular abnormality seen in this patient? Option A, esophageal varices. Option B, left-sided ankle swelling, periumbilical venous distension, rectal varices, then varicocele. Pause it and give the answer. So the correct answer for this question is varicocele. Why? Let us see to the explanation, right? Okay, so if we look to the renal vein, right, the left renal vein is a little bit longer than right renal vein. The other thing to be noted is the right spermatic or gonadal vein, right, that drains directly to the inferior vena cava, right, like over here we can see directly drain. But this is not the case of left spermatic or gonadal vein. What would happen, that would drain first into the left renal vein, right, like we can see if we follow this, it would drain into the left renal vein, right, and then this left renal vein would drain into the what that into the inferior vena cava. The other thing is this renal vein, left renal vein, is in between the aorta, and this one is the superior mesenteric artery, and it is compressed uh, in between these two arteries, like superior mesenteric artery and with that inferior vena cava. So that would produce compression, and that would increase the pressure. That is called nutcracker effect. We would talk about that, right? So whenever the pressure is raised in the left spermatic or gonadal vein, okay, that would cause dilation of the palm venous plexus. That is considered as varicocele, right? So the aorta and superior mesenteric artery compresses the left renal vein, increases pressure in the left renal vein, causes retrograde blood flow to the testes and dilation of the tympaniform venous plexus, right? Okay. The right renal vein is relatively short structure, okay, runs interior to the right renal artery before joining the inferior vena cava. The right gonadal vein also drains directly into the inferior vena cava. I talked about this. Left renal vein is significantly longer, right? That runs posterior to the splenic vein and crossing the beneath the superior mesenteric artery. I talked about this. Okay, the left gonadal vein joins the left renal vein, right? Upstream of which it crosses the aorta and doesn't enter the inferior vena cava directly. We talked about this thing, right? So the pressure within the left renal vein is often higher than on the right due to compression between the aorta and superior mesenteric artery. That is called nutcracker effect. We talked about this. Now, pressure in the left renal vein can also be elevated due to compression from left-sided abdominal or retroperitoneal masses. Okay, persistently elevated pressure in the left renal vein can cause flank pain, right, or abdominal pain, right, along with gross or microscopic hematuria, right? That is called left renal vein entrapment syndrome, right? Point to be noted. Now, increased pressure in the left gonadal vein results in wall leaflet failure and varices of the testicular pampiliform plexus that would lead to varicocele. Okay, so one option is C and the esophageal varices, rectal varices, and periumbilical venous distension. These are the signs of portal venous hypertension. They are the part of the portal venous hypertension, but the renal veins are not the part of the portal system, right? Unilateral left-sided ankle swelling can result from many causes, including obstruction of left common iliac vein, point to be noted, left external iliac vein, right, with that left renal vein, left femoral vein, right, that would lead to unilateral left-sided ankle swelling, or any other major veins of the leg, left leg, right? Okay, but this is not associated with the left renal vein. Okay, so the pressure in the left renal vein may become elevated due to compression where the vein crosses the aorta beneath the superior mesenteric artery. The this nutcracker effect can cause hematuria and flank pain, right? Pressure can also be elevated in the left gonadal vein that would lead to formation of varicocele. Okay. In question number 24, a 51-year-old man is brought to the emergency department due to chest tightness and that started 30 minutes prior to arrival. Okay, his chest discomfort is associated with shortness of breath and nausea. The patient was shoveling snow off his driveway when his symptoms began. He has a history of hypertension and type 2 diabetes mellitus. Okay, initial ECG shows LSD elevation in lead 1 and AVL. Point to be noted. I would talk about that. Cardiac enzymes are elevated. Emergent cardiac catheterization in this patient will most likely show occlusion of which of the following arteries, right? So the options are distal LAD, that is left anterior descending artery, left circumflex artery, left main coronary artery, proximal left anterior descending artery, right coronary artery, right? Pause it and give the answer. So the correct answer for this question is left circumflex artery because the lead 1 and lead AVL here L comes, so that would be for left side. So left circumflex, that would be for lateral side. That is supplied by left circumflex artery, right? Why not the other? We would talk about that, right? So the correct answer for this is left circumflex artery, right? So if you look to the heart, right, uh, this is the interior side of the heart, right? This is V1 and V2. That would be supplied by proximal LED. V3 and V4 that would supply the distal. Okay, this that is supplied by LED but distal, right? And V5, V6, and lead 1 and with that we have AVL. They are used for lateral side, anterolateral. Okay, and with that AVR is for right side, and with that we have lead 2, 3, and AVF. Okay, 2, 3, and AVF, they are used for inferior wall MI, right? Now let us see to the explanation further. This patient with ST elevations. So this patient with ST elevation and lead 1 NABL, most likely has an acute lateral myocardial infarction due to the occlusion of left circumflex artery. Okay, ECGs are useful in the diagnosis of MI and may help localize the area of infection. ST elevations typically represent acute MI. Point to be noted. This thing is important, right? ST elevations typically represent acute MI, whereas prominent Q waves, right, are suggestive of old MI, right? Okay, this is important. Leads 1 and AVL, they correspond to the lateral limb leads, right? On ECG. Therefore, as the elevation or Q waves in these leads are indicative of infarction involving the lateral aspect of left ventricle. This is important because the chest leads V5, V6 are also laterally placed, right? They may also show ST elevation during the lateral infarction, right? As I talked about this, the lateral aspect of the left ventricle is supplied by the left circumflex artery, which originates from the left main coronary artery, right? Why not option D and A? The left anterior descending artery, that is LAD, primarily supplies the anterior aspect of the left ventricle and interventricular septum, that is septal branches, which corresponds to the anterior chest leads from V1 to V4. V1 to V4, right? Now, proximal occlusion. If there is proximal occlusion of LAD, that would lead to they would involve all of these leads, right? However, if there is distal lead occlusion, just only distal lead occlusion, that would spares the septal leads V1, V2. That would involve only V3 and V4, right? Okay. Why not option C? Because the left main coronary artery give rise to the LAD and left circumflex arteries, right? Let's say if this is left main coronary artery, that would give rise to a left circumflex artery with that LID, left anterior descending artery, right? So lateral and this one anterior, right? Okay. So therefore, left main coronary artery occlusion typically results in anterolateral infarction, which corresponds to ST elevation in interior, that is V1 to V4, right? With that lateral V5, V6, 1 and AVL, right? Okay. Uh, so why not option E? Because the right coronary artery that would supply inferior portion of the ventricle, right? So if there is occlusion of that artery, that would result in inferior MI, and that would involve the leads 2, 3 and EVF, right? So right coronary artery typically supplies the right ventricle and inferior aspect of the left ventricle. Occlusion of this vessel therefore results in inferior MI, which corresponds to the ST elevation in inferior leads 2, 3 EVF. Okay. So, leads 1 enable correspond to the lateral aspect of leads on ECG. Therefore, ST elevation RQ waves in these leads are indicative of infarction involving the lateral aspect of left ventricle, right? Which is supplied by the left circumflex artery. This is important, right? So, question number 25. A 54-year-old man comes to the office due to episodic burning substernal chest pain. His pain increases with activity and improves with rest. The patient has a history of hypertension and hyperlipidemia. He has smoked a pack of cigarettes daily for the past 30 years. His BP is 140 by 85 mm of mercury and pulse is 76 per minute. Cardiac auscultation reveals is 4 hertz sound. Point to be noted. Lung are lung and abdominal sorry lung and abdominal examinations are unremarkable. In ECG, it rest shows left ventricular hypertrophy. Right, a myocardial perfusion scan reveals inducible ischemia of the inferior surface of the heart. Inferior surface of the heart. Point to be noted. We earlier talked about this case, right? Which of the following coronary arteries is most likely occluded in this patient? Option A, LAD, that is left anterior descending artery. Option B, left circumflex coronary artery. Option C, left main coronary artery. Option D, right coronary artery. Option E, right marginal artery, right marginal branch. Pause it and give the answer. So the correct answer for this question is, in my opinion, right coronary artery, right? Because this is right shunt. Yeah, I'm right. So if we look to the heart blood supply, we have right coronary artery and we have left main coronary artery. The left main coronary artery, that would be divided into left circumflex, and with that LID, left anterior descending artery, right? And when we go down, so that would give rise to interventricular septal branches, right? And if we go on the right side, we have right coronary artery, that would give rise to the right marginal branches, right? Okay. Okay, if we go in the upward, the SA node and AV node, okay, they are also supplied by this main dominant circulation. For example, in most of the people, it is from right coronary artery, right? Okay. So the right and left main coronary artery arises directly from the root of aorta, point to be noted, right? They are arising from aorta, okay? So provides the blood supply to the heart. Left main coronary artery divides into the left interior descending artery, that is LID, with that circumflex arteries. We talked about this, uh, which supply most of the interior and left lateral surfaces of the heart, right? Okay. In 85 to 90% individuals, right coronary artery give rise to PDA, that is posterior descending artery. Such patients are said to have a right dominant coronary circulation, right? The posterior descending artery, PDA, runs down the posterior interventricular groove and supplies the posterior one-third of the interventricular septum. That means it is supplying posterior surface, right? And most of the inferior wall of the left ventricle, inferior wall, right? Okay, this is important. The inferior diaphragmatic surface of the heart is formed by the left ventricle, two-thirds, right, and right ventricle, that is one-third, right, separated by the posterior interventricular groove. Because most individuals have right dominant circulation, occlusion of the right coronary artery most likely to cause inducible ischemia of the inferior surface of the heart, right? Okay. Why not option A? Because LID normally supplies the interior two-third of the interventricular septum by septal branches and interior wall of the left ventricle by diagonal branches, and with that part of the interior papillary muscle, right? Okay. Then why not option B? The left circumflex coronary artery usually supplies the lateral and posterior superior walls of the left ventricle via obtuse marginal branches. So it would give rise to marginal branches, right? Okay. Why not option C? Because in 10% of the individuals, PDA arise from the circumflex branch of the left main coronary artery, that is called left dominant circulation. Left main coronary artery is not artery most likely occluded in this patient, right? Okay. Why not option E? Because the right marginal branch that would supply the wall of the right ventricle, and it can also provide collateral circulation in patient with LID, right? Collateral circulation. Okay, so the inferior wall of the left ventricle forms most of the inferior diaphragmatic surface of the heart and is supplied by the PDA, right? PDA, posterior descending artery. In 85 to 90% of individuals, the posterior descending artery derives from the right coronary artery, right dominant circulation. Let's say, if, like they have discussed this case in another case, if this patient is of left dominant, right? If this patient is of left dominant, that this PDA would be derived from left circumflex, right? So in that case, there would be the occlusion of left circumflex artery, right? That would lead to what? The ischemia of the inferior wall. Okay. Now question number 26. We have a 23-year-old woman who is brought to the emergency department with chest wound, right? Okay. She was in her house during a severe thunderstorm when a large tree branch fell to a window. The window was shattered and large fragments of wood and glass struck the patient. She didn't lose consciousness, but her family found her bleeding profusely and rushed her to the hospital. BP is 80 by 50 mm of mercury, and pulse is 130, right? High pulse, okay? 130 per minute. The patient appears to be in severe distress, right? Okay. Physical examination shows a deep penetrating wound in the fourth intercostal space along the left sternal border. This is important point regarding this MCQ, right? Smaller lacerations are noted across the face and forearms. Which of the following structure is most likely injured in this patient? Option A, inferior vena cava. Option B, left atrium. Option C, left ventricle. Option D, pulmonary trunk. Option E, right ventricle. Pause it and give the answer. So the correct answer for this question is option E. Okay, why? Because here, if there is injury to the fourth intercostal space, that would affect right ventricle, right? But if the important point regarding another MCQ is, if there is injury to the fifth intercostal space along the midclavicular line, that would affect the left ventricle, right? And with that, lung, right? This is important. Okay, so the correct answer for this question is right ventricle. Okay, good. Let us see to the explanation. So if we have left peristernal impalement wound, okay, that would let's say in fourth intercostal space, right? Okay, so that would spare parietal pleura, right? Okay, because there is no middle lobe on the left side in the fourth intercostal space. Okay, so a minute. So a penetrating injury at the left sternal border in the fourth intercostal space, that is the level of nipple, will pass to the following layers in order, right? So like skin and subcutaneous pectoralis major muscle, external intercostal membrane, internal intercostal muscle, internal thoracic artery and veins, and with that transversus thoracic muscle, parietal pleura, pericardium, and right ventricular myocardium. So the right ventricle composes the majority of the interior surface of the heart and is at risk of injury with penetrating trauma at the mid and lower left sternal border, right? This is important. Now, this point is important. The parietal pleura is injured as well, but the left lung would be not punctured. This is important in case of fourth intercostal space, right? The parietal pleura will be involved, that would be injured, but the lung would be not punctured. Is there is no middle lobe of the on the left side of the heart, as I talked about this, right? And the superior lobe of the left lung is displaced laterally by the cardiac impression. Why not option A? Because inferior vena cava, that passes through the right side of the central tendon of the diaphragm at the level of T8, penetrating wound to the back. First point to be remembered, right? This is important. Immediate right of the vertebral bodies could strike the inferior vena cava. Why not option B? Because that is the most posterior part, right, of the heart. So left atrium is located at the base of the heart, posterior surface opposite at the apex, and makes up the most heart's posterior surface. Only the auricle of the left atrium is visible anteriorly, protruding between the pulmonary trunk and the left ventricle, right? Why not option C? Because the left ventricle composes the left lateral aspect of the heart. A stab wound angled slightly medially in fourth intercostal space at the midclavicular line could strike the left ventricle. Right? This is important. At the midclavicular line, right? But only after passing through the bulk of the left lung. So that means in that case we would also injured first we would injure left lung, then we can reach to the left ventricle. This is important. Then why not option D? The pulmonary trunk could be pierced by penetrating injury to the second intercostal space at the left sternal border, right? Because is we would talk about let me remove this. If let's say this is the heart, right? uh, we have, let's say if the aorta is on the left side, there is crossing over, that would be shifted to the right side Okay. Um, in the second intercostal space, on the right side, but we have uh, pulmonary artery that is on the right side, that would be shifted to the left side in the second intercostal space, right? So that's why second intercostal space at the left sternal border, right? So the right ventricle composes most of the heart's interior surface. A deep penetrating injury at the left sternal border in the fourth intercostal space puncture the right ventricle. So in question number 27, we have a 45-year-old man comes to the clinic due to frequent episodes of palpitations accompanied by dizziness, fatigue, and shortness of breath. Prolonged ECG monitoring identifies episodes of atrial fibrillation, right, associated with a rapid ventricular response rate. A radio frequency ablation of ablation procedure is planned. Okay, the exit site is the right femoral vein. The ablation catheter is advanced to the left atrium, where radio frequency energy is used to eliminate an ectopic focus of abnormal electrical activity. During the procedure, the catheter most likely passes through which of the following structures, right? So option A, aortic valve; option B, endarterial septum; option C, interventricular septum; option D, pulmonic valve; option E, tricuspid valve. Pause it and give the answer. So the correct answer for this question is option B, right? Why? Let us see to the explanation. A venous catheter traveling from the femoral vein into the heart passes to the iliac vein and then into the inferior vena cava to reach the right atrium, right? Once in the right atrium, structures within the right side of the heart and pulmonary arteries are readily accessible, right? However, because the pulmonary capillaries are far too small to pass through, the left side of the heart must be accessed by traversing the interatrial septum, right? The interatrial septum is traversed at the site of foramen ovale, right? Which in adults is typically covered by a thin membrane of fibrous tissue that can be easily punctured, right? Entry into the left atrium allows for the direct measurement of left atrial pressure rather than an estimate via pulmonary capillary wedge pressure. This is important, right? Which is not a direct method, right? And for access to arrhythmogenic foci that may be located on the left atrial myocardium or pulmonary veins. Following the procedure, the small ASD created by the catheter typically closes spontaneously, right? Why not option A? Because arterial catheterization of left side of the heart typically starts in the femoral or radial artery and proceeds to the ascending aorta. Okay, where pressure can be bared or dye can be placed into the coronary arteries to visualize atherosclerotic obstruction, that is coronary angiography. In addition, the aortic valve may be crossed to measure the left ventricular pressure, right? However, retrograde crossing of structurally complex mitral valve is highly difficult and the left atrium is not accessed via this route. So they mean to say, let's say if this is the heart right over here, if let's say if you're passing, let's say over, let me draw this. Okay, once again. Okay, and let's say this is the herd, right? We are approaching from femoral artery or radial artery. This is the sending aorta, let's say, all those things. And then over here, if we have like over here we have aortic valve, so it can pass easily through this thing. But it is so due to that we can measure this pressure of the ventricular chamber, but we cannot pass through this mitral valve into the left area to measure that pressure, right? So that's why we cannot use this thing for left atrial pressure, right? Okay. Why not option C? The interventricular septum. The interventricular septum is not traversed during the heart catheterization because myocardium is thick. Myocardium over there is thick and difficult to puncture, right? and a high left ventricular pressure would likely to prevent spontaneous closure of the VSD that is created, right? Okay. Why not option D and E? Because the tricuspid valve is crossed during venous catheterization to access the right ventricle, right? And pulmonic valve is subsequently crossed to access the pulmonary arteries. However, because the catheter cannot pass to the pulmonary capillaries, the left atrium cannot be accessed via this route. They mean to say, let's say, let me draw this. Let me draw this for you guys. Okay, let's say if this is the heart, right? Over here we have inferior vena cava, we have superior vena cava. If let's say if we get enter over here into the right area, right? So over here we can measure this pressure, then we can cross through this tricuspid one, then we can measure this pressure, then we would come into the pulmonary artery. We can measure this pressure, but we cannot cross to pulmonary capillaries, right? So that's why we would use this way, quick way, right? And easy way. So we would pass through the foramen veil and we can measure this pressure, right? Okay, good. So the axis to access the left side of the heart, cardiac venous catheters must cross the interatrial septum at the site of foramen veil. Entry into the left atrium allows for direct measurement of left atrial pressure. For access to arrhythmogenic foci on the left atrial myocardium are pulmonary veins, right? So I think this is enough for today, because in the next session we would finish this block. Okay.